I'd like to thank the organizers for inviting us today to present on hereditary Pheochromocytomas and paragangliomas. This session will be co-presented by myself, Leah Mahmood. I'm one of the pediatric residents at UT Health San Antonio, and by Dr. Patricia Dye, who will be presenting virtually. Here is an outline of the presentation. Oh, disclosures, we have nothing to disclose. All right, so this is our outline. So I'll go ahead and start with the case presentation. And then Dr. Dye will follow with her virtual presentation with an overview of pheochromocytomas and paragangliomas, a comparison between adult and pediatric paragangliomas, and also going over some of the challenges in hereditary paragangliomas. All right. So this is our patient case. So this is a 15-year-old female who initially presented to her OB/GYN clinic with abnormal uterine bleeding and was found to have an ovarian cyst on ultrasound, as well as systolic blood pressure of 170. She was sent to the ED at that point and was noted to have hyperglycemia. When she was admitted to our hospital, her A1C was actually 12.5. And our exam was mainly significant for acanthosis, obesity, and abdominal striae. Now you can see here on the family history some of the pertinent findings. So both of her parents have type 2 diabetes. Her sister does have an ovarian cyst. And most importantly, her mother had passed away a few years ago from a malignant, poorly differentiated islet cell tumor. So her initial labs were not significant apart from hyperglycemia. And I'll go over a little bit in more detail her endocrinology labs in the next coming slides. As part of her hypertension workup, we obtained a renal ultrasound, which was negative for renal artery stenosis, but incidentally did show a diffusely echogenic liver with a right hepatic lobe mass and a large adnexal mass. Now, we did obtain further imaging just because of the renal ultrasound finding, and with ultrasound did show presence of a solid on the left side adnexal mass and a right para-ovarian cyst. And to further characterize the findings, we did obtain an abdominal and pelvic MRI without contrast, which showed a complex solid enhancing left adnexal mass concerning for neoplasm. Now, additional findings on abdominal MRI showed lesions within the body and tail, a right adrenal mass, and multiple liver lesions in the background of fatty liver. Now, other findings included a solitary mass on the right lung, pancreatic nodules, and a proximal right humerus lesion, as well as a hypodensity in the posterior pituitary region. Everyone later on did more of a cyst. We did have, compared with all of the imaging up to this point, the patient is also undergoing an endocrinology workup. We have summarized the most relevant findings here. And as you can see, her plasma norepinephrine level was elevated at 5.84, and her 24-hour norepinephrine level was also elevated. Chronogranule A and estradiol levels were both elevated, but her AI cortisol and her ACTH were both normal. And as you can see on the bottom of the slide, her other levels were normal as well. Her thyroid levels were normal and her fat levels were normal. So to summarize our clinical picture thus far, we have an adrenal mass, an ovarian mass, pancreatic mass, and a liver nodule in the setting of fatty liver, a lung nodule and a lesion on the humerus, as well as a mass in the posterior pituitary region. Were all of these findings related, or is this a sign of more metastatic disease? And if so, our main question is, how do we determine the primary tumor? So this is where we resort to functional imaging and try to identify how all of these lesions relate to each other, if they're related to each other. So we started IVG scan as we were initially unable to perform a scan while the patient was admitted. The scan is posterior view, so what you're looking at here is the uptake within the right adrenal gland, but not the liver, the pancreas, or the ovaries. Now, on Trioxide Scan, it showed, it was interesting because it showed radiolaser uptake in the adrenal gland, but not, sorry. So it did not show uptake in the, it did show abnormal intense uptake in the solid left ovarian mass, but not in the right adrenal or the pancreatic liver lesions. This is the image right here. Now, on biopsy, we obtained an ultrasound-guided liver biopsy, which did show benign parenchyma, and an FNA of the neck of the pancreas was consistent with the pancreatic neuroendocrine tumor. The findings were more suggestive that the pancreatic lesions were multiple primary lesions and not a sign of metastasis from the pheochromocytoma. All right, so I want to take a moment to go over the patient's clinical course up to this point. Now, as I said initially, her A1C on admission was 12.5, and so she was started on a full insulin regimen. For her hypertension, she was started on lisinopril, but when the findings were more suggestive of a pheochromocytoma, we switched her to doxazosin for alpha blockade, with the goal systolic blood pressure less than 115. Her pheochroma was later resected. And for her adnexal solid mass, it was resected at a later date along with the ovarian cyst, and the mass was found to be a steroid cell tumor. Now, the pancreatic lesions did require further workup, and so after resection of the right adrenal gland and left ovarian mass, the Hereditary scan was performed, which showed multiple avid lesions in the pancreas, consistent with a neuroendocrine tumor, as you can see in the bottom. So because of the family history and all of the findings summarized this far, our concern for familial cancer syndrome led us to order a genetic test, which should confirm a diagnosis of von Hippel-Lindau disease. And so because of that, all of the other family members were also tested. And so her sister was found to be a carrier for the VHL variant, and her brother and father were unfortunately negative for VHL. So we did conclude that her mother was a carrier of this disease. And so following up with this patient, so after her resection of the adrenal gland, her hypertension did resolve and she no longer requires insulin, but because of lifestyle factors, she does continue to have insulin resistance with an A1C of 7.2 on clinic follow-up. She's being treated with metformin. On her lab follow-up, she did have a normal functionated plasma catecholamines, metanephrines, and chromogranin A. So this is part of her extended VHL surveillance in clinic. So she does follow up every 3 months in the pediatric hematology oncology clinic. And so as part of her workup thus far, we did have a hearing evaluation, which was normal, and a stable abdominal MRI on her 3-month follow-up. Did not show any recurrence of pheochromocytoma and no new kidney masses. The MRIs of the spine and internal auditory canals were both normal, and she does have a next Hereditary scan July of this year. So with that, I'll go ahead and turn it over to Dara, who will go over pheochromocytomas and paragangliomas in more detail. Thank you.
Thank you very much, Dr. Mahmoud. This is an intriguing case that illustrates the complexity of presentation of pheochromocytomas and paragangliomas in pediatric patients. I would like now to briefly review pheochromocytomas and paragangliomas and highlight unique aspects of this patient, diagnosis and follow-up. So as most of you know, pheochromocytoma is a term that we use for tumors that arise from the adrenal medulla, while paragangliomas are the tumors that arise from similar tissue found outside the adrenal gland. And these are neurocrest lineage cells of autonomic nervous origin. These tumors are rare. They produce catecholamines, adrenaline or epinephrine and norepinephrine, and are a very rare cause of hypertension. Malignancy in pheochromocytomas and paragangliomas, which I'll refer to for short as PPGLs from now on, malignancy occurs in approximately 15% of the cases and can only be defined by the presence of metastasis, which makes it a late diagnosis. Uniquely, these tumors are often components of various hereditary cancer syndromes, and they are most commonly heritable of all human tumors. Approximately 40% of them are associated with an inheritable germline mutation. Next slide, please. Dr. Mahmoud, if you could just move to the next slide. I wonder if I can, yeah. Yes, thank you. The diagnosis of PPGLs can happen in either symptomatic patients with catecholamine hypersecretion or found as an incidental mass. And the challenge is to establish the evidence biochemically of catecholamine hypersecretion and identify imaging. So the metabolites, metanephrines and normetanephrines, are more sensitive in plasma and urine than the catecholamines themselves. And imaging, usually by CT or MRI, can detect one or multiple tumors and can be supplemented by functional imaging with MIBG, gallium dotatate PET-CT scan, or fluorodeoxyglucose PET-CT. Typically, the treatment is primarily surgical, but for recurrent or inoperable tumors, treatment options may include therapeutic MIBG, systemic chemotherapy, and targeted therapy. In view of the high rate of inherited PPGLs and chances of recurrence or additional tumors, it is recommended that these patients remain under surveillance lifelong with regular biochemical and imaging assessment. Now, there are important differences between PPGLs that present in adults versus children. If you could have the next slide, please. Which are summarized here from a recent publication with the largest cohort of pediatric PPGL. So other than the age, the distribution of sex is not very different, but pediatric patients tend to have more often than adult patients extraadrenal tumors or perigangliomas relative to pheochromocytomas. Pediatric individuals also are more likely to have multiple lesions, and those could be bilateral pheos, multiple perigangliomas, or a combination of pheos and perigangliomas. They are more often metastatic, and almost invariably, they have noradrenergic or norepinephric secretion compared to adults. Their hereditary component, not surprisingly, is higher than in adults. Next slide, please. So this is the table that lists the most well-established syndromes, PPGL syndromes, inherited syndromes that have been identified. So in addition to VHL disease that I will go into more detail that reflects our case today, there are other well-known syndromes, PPGL syndromes, multiple endocrine neoplasia type 2A and type 2B, which are caused by RET mutations, familial paraganglioma syndromes types 1 through 5 that are due to mutations in succinate dehydrogenase subunits A, B, C, D, and the associated factor AF2, neurofibromatosis type 1, other less known familial pheochromocytoma syndromes that are related to other genes. So most of these are associated with other tumors or other manifestations, MEN being classically very well established, and less commonly on the other periganglioma syndromes, the presence of renal cell carcinoma or gastrointestinal stromal tumors and others. Next slide, please. The distribution of these various syndromes varies according to age. And as you can see on the left-hand side, the pediatric group by far has the highest incidence of VHL-related mutations and secondarily succinate dehydrogenase mutations as well. And as patients grow older, the percentage of somatic events that are not inherited become greater. Next slide, please. And in part, this is explained by the molecular basis of PPGLs. So these are generally known to be genetically silent tumors, but they can be divided into different clusters, or 3 clusters, in which one cluster is enriched for pseudohypoxic or hypoxia-related expression. A second cluster is associated with kinase signaling, and the most recently identified cluster is associated with Wnt pathway alterations. And these clusters reflect the genetic association and the genetic driver event. So usually PPGLs are caused by mutation on a single gene, which is mutually exclusive with the others. And there are more than 20 driver genes that have been associated. Next, please. So in part, this reflects that the fact that in younger patients, the genes that cause pheochromocytoma are almost invariably related to hypoxic events. So mutations in VHL, SDH, B or D are the most common ones in these patients. These are tumors that are associated with expression of catecholamine profile of norepinephrine secretion. And this is the cluster of the youngest group of PPGL patients. Next slide. This is relevant because it explains why patients with pediatric PPGLs tend to have this profile of norepinephrine secretion, more commonly extraadrenal tumors and metastatic disease, as SDH are associated with a higher risk for metastatic disease in PPGLs. So the grouping of pediatric PPGLs is mostly explained by the type of mutation that these patients have often. So this is relevant for clinical planning, for pre-surgical, post-surgical management of not just the patient, but also their family members. Next slide. Let's focus now on VHL disease, which is the diagnosis of our patient today. This is an autosomal dominant disease that is present in 1 at every 36,000 births. It has a potential to impact multiple tissues of various embryonic origins. The most common manifestations of the disease are renal cell carcinoma, hemangioblastomas of the retina and the central nervous system, pheochromocytomas, pancreatic, cysts and tumors, and cysts in other organs such as kidney and adnexal mass, adnexal region, gonadal region, lungs, etc. So this is a high penetrance disease in which almost all patients will develop the disease when they are carriers over their lifetime. They are caused by mutation on a single gene, the VHL gene, and there are genotype-phenotype associations that make the basis of the disease classification. And pheochromocytomas are, in fact, the basis of this classification. Next, please. So the disease is associated with low risk of pheochromocytomas considered type 1, and high risk of pheochromocytomas are considered type 2. So these pheochromocytomas overall represent about 50% of the patients with VHL disease. Next, please. There are multiple classifications of the disease, and these are based on the distribution of the most important manifestations of the disease. As you can see here, type 1 has higher incidence of retinal and central nervous system hemangioblastomas and renal cell carcinomas, but pheochromocytomas are rare. And the mutations that are associated with the disease usually are the truncating type, in which the entire VHL gene is deleted or some exons of the gene are deleted. This contrasts with type 2 disease, in which the mutations tend to be missense different locations and different distributions in which pheochromocytoma is the main phenotype, but can be associated with either hemangioblastomas, predominantly in the type 2A, or renal cell carcinoma in the type 2B, and pheo alone or with other rare incidences in type 2C. So we can see that this patient, based on the presence of pheochromocytoma, is a type 2 VHL. Next, please. But if we look at the family pedigree and take into account the entire clinical manifestations of the proband highlighted here at the bottom, we see that she had pheochromocytoma, pancreatic masses, and adnexal disease, a rare manifestation of VHL. And so far, no hemangioblastomas or no renal cell carcinoma have been found. So she seems to be in a typical case. And based on her mutation, she would not be a classic type 2C VHL patient. So she fits more likely into an atypical form of 2B. And I should say here that more recently, this classification has been considered to be a dynamic classification even, because patients might develop different manifestations of the disease over time. So it is premature to try and fit in a patient based on the onset presentation, but rather it's a long-term observation to define the subclassification. Next, please. So the VHL Alliance and a committee of investigators, clinical and basic investigators in the area, have defined guidelines for the surveillance which our patient is undergoing right now. So it varies from the type of screening that the patients undergo once they are established as carriers of the disease. Starting with retina screens from a very early age, 1 year of age, all the way to looking for abdominal masses in the kidney, adrenal, or pancreas at around 15 years of age, and continuing yearly or every 2 years until about age 65, by which time the established clinical manifestations of the disease are expected to be fully penetrant. Next, please. So I wanted to spend some time talking about the pancreatic neuroendocrine tumor in this particular patient. So typically, pancreatic disease is present in about no more than 20% of the patients, usually less than that. And pancreatic neuroendocrine tumors tend to be more frequently of the sporadic type rather than the VHL disease. And if we compare the two types, they are more often secreting of hormones in the sporadic disease compared to VHL cases. Very rarely in VHL, these tumors are high grade, and they are less likely to develop metastases than in the sporadic forms. So the age of onset of the disease is on median is 31 years of age, and our patient falls within the very low end of the curve of pancreatic disease presentation. Now, she does have some features that are of some concern. The type of mutation that she has, the arginine 167 tryptophan, is often associated with more aggressive forms of the disease. But the tumor size and tumor grade are also defining features of the prognostic, and in that particular case, so far, she has remained stable. Now, some of the most important markers of aggressiveness will be the tumor doubling time. And we do notice also that her mother had an aggressive form of pancreatic neuroendocrine tumor. Next slide. How these tumors are assessed currently. The guidelines have been established predominantly for the sporadic forms, and they are based on screening by imaging, in which using MRI or gallium dotatate are used to establish the doubling rate of the tumors. And when possible, these tumors can also be screened by serum biomarkers such as chromogranin. You have noticed that this patient had an initial elevated chromogranin, but we believe that it was mostly associated with her pheochromocytomas, since the chromogranin has normalized after surgery. So in this particular case, chromogranin has not, cannot, or is unlikely to be used as a marker for the pancreatic masses. Now, what was suggested for this patient was, in respect with her pancreatic tumors, were a surveillance step, and the reason was that she had multiple masses on her head, body, and tail of pancreas, and removal would imply a very extensive loss of pancreatic mass. And instead, it was opted for surveillance for evaluation of her doubling rate instead. Now, in addition to surgery, are there other options that this patient can take advantage of? Next slide, please. I wanted to briefly talk about the molecular features of VHL disease and what we know about it. So VHL is a part of a protein complex that is involved in the degradation of hypoxia-inducible factor, transcription factors that are relevant for the hypoxic response. So in the absence of VHL function, next slide, there is an accumulation of HIF, or the hypoxia-inducible factors that are no longer degraded, and activation of a number of downstream target genes that lead to tumor growth. So the hypoxia-inducible factors are very critically relevant for the development of tumors in VHL. And in theory, the use of HIF inhibitors would be would have a relevant rationale for treating these patients. Next, please. So it is also known that depending on the type of lesion that the patients have, there is an increased accumulation of HIF, and therefore there would be potentially a benefit in inhibiting HIF as a form of treatment. Next. Next slide, please. So research over the past 5 years have led to the discovery of a specific small molecule inhibitor of HIF-2 alpha, one of the HIF subunits, and the one that is believed to be most relevant for VHL. This drug is now known as belzutifan and has been FDA approved very recently. So there are two main reports suggesting that this drug is very effective in advanced renal cell carcinoma, and those are from patients with sporadic disease in which somatic mutations of VHL, not necessarily germline mutations, are the cause, a main molecular cause of this tumor growth. And also very relevant to this presentation, late last year, there was the first report of the use of belzutifan in patients with von Hippel-Lindau. And the promising responses that were observed, including an objective response ratio in renal cell carcinoma of about 50%, an impressive response of almost 80% in patients that also had associated pancreatic neuroendocrine tumor, and about 30% of response in patients with hemangioblastoma. So these promising results have now led to new trials, including the one listed here that was launched late last year to treat advanced pheochromocytomas and perigangliomas and pancreatic neuroendocrine tumors. And this is open for patients with age 12 and older. So this may be an interesting avenue for patients that have multiple tumors, recurrent tumors, and may not be operable. So there will be more data coming from this trial in the future, and will inform on pediatric cases. So I wanted to finish the presentation with just touching on a little bit about new research that has been going on in patients with VHL disease and PPGLs in particular. So unlike many forms of common cancer, rare cancers have lagged behind in terms of the existence of models that can help us understand the disease and use it for preclinical drug testing. And that includes cell lines, genetic mouse models, and we have been trying to establish new ways of studying these tumors, in particular PPGLs. So next slide, please. We started a collaboration with a colleague at UCLA, Dr. Sorani, to develop organoids of patients with PPGLs of various genetic origins, including VHL tumors. And we have begun this work and started to have preliminary data suggesting that we can indeed develop organoids of PPGLs, and we will provide immunohistochemistry analysis. We will measure catecholamine secretion on these tumors. We will evaluate the cell composition and the molecular composition of these tumors, as well as make them available for drug screening that could potentially point to new avenues for treatment that are personalized to individual patient organoids. So we're excited about this project nowadays, and we're collecting samples at this point. Next slide. So I wanted to conclude by discussing what we presented today. So this was an exemplar of an atypical and challenging presentation of a well-known disease, VHL, showing the impact that the diagnosis had on planning the patient's therapy and surveillance plans, how this can also be extended and was extended to other family members, and how it can affect their follow-up as well. We talked about new avenues for therapy and where the research is headed in this area. Next slide. I would like to thank all of our collaborators in the clinic, and I highlighted them here. It was an amazing multidisciplinary team at UT Health San Antonio who participated in the care of this patient and her family and continue to follow them. I also wanted to thank the lab team who has been working in research of pheochromocytomas and paragangliomas with me for many years. Thank our collaborators in the clinic, in the lab, and within US and outside. And also thank our funding sources